see here. Welcome. So glad to have such great attendance and participation. This has just been a lot of great conversation and a lot of valuable information. So just love to see this engagement. Thanks for being here today. My name is Nate Nye. I'm the chair of the Sports Ultrasound Committee. I'm a primary care sports medicine, family medicine physician. And I will be moderating this session. We'll be going over common questions about orthobiologics. Get your notepads or whatever device out, because I promise you there will be things you want to write down. And this session is intended to be punchy and applicable, practical, and a lot of stuff that you can actually take home and use. I want you to be thinking of what are the questions that you have. Again, there's a lot of good questions coming out of the previous session. What questions do you still have? Open up your app if you're not familiar with the Event Mobi app. Load the session that we're in, which is the Orthobiologics Pre-Conference. Go to the Q&A and start loading in questions. And upvote and downvote the ones you want to see. This session is going to be broken up into a few segments. We are approaching this as what questions do patients ask you and how do you respond? What questions do fellows ask you and how do you respond to a fellow? And what about questions amongst our colleagues? And how do we talk to each other about these things? So, all right, without further ado, we're going to go ahead and introduce our panel. A number of just the best experts that are out there in our country right now. So I'm very honored and very grateful for all of them being here today. They're lined up in order. I'm going to go from right to left, or from left to right for you. Gary Ho is a colleague and friend of mine. He's been a mentor ever since I was very early in my career. So I've been fortunate to know Gary. Gary has a number of academic appointments. He's board certified in family medicine, sports medicine. He is a true wizard, my word. He is a wizard of musculoskeletal and neuromuscular ultrasound. He teaches internationally. In addition to ultrasound, he is an expert in running medicine, martial arts, combative sports, regenerative medicine, orthobiologic therapies, office procedures of number of different types, concussion, mechanical peripheral neuropathies, academic medicine. He lives in the Washington, D.C. area, and he serves his community as a sports medicine physician at Ortho Virginia in Fairfax. He is a past director of the Fairfax Family Practice Sports Medicine Fellowship Program, and he has served as a team physician for a number of professional collegiate teams and is currently with George Mason University. So glad to have Gary. The format, again, is patient questions. How does PRP work? Dr. Ho will answer that. So without further ado, we'll hand it over to Dr. Ho. Thanks.
All right, good morning, everybody. Thanks for the invite and putting this all together to all the organizers. I really appreciate the forum. So this question is directed to patients, and I think when it comes to educating our patients, it's important to explain it in terms, of course, that they would understand. I use a lot of visual aids, and I use a lot of analogies in order to kind of help bring a patient to understand what we're actually trying to accomplish. Getting buy-in is really helpful. I think it does have meaningful contributions to their outcomes. So the first thing is I have no relevant financial disclosures about what I'm going to talk about. So I use a lot of visual aids. What you see on the screen now is a poster. It seems really busy, but it's a really big poster. It takes up like half the wall in my procedure room, so I can use this to educate patients. But the way I kind of describe how PRP works for the lay public, and it kind of depends on their level of education, but most of the patients in the Washington, D.C. area who come to see me are already pretty invested in doing their quote unquote their research on Google. So they come in with some basic understanding, but I'll still kind of describe this a little bit in terms that they would understand with an everyday experience. So I say that, when we're using PRP or platelet-rich plasma, our goal is to kind of harness a component of the blood that plays a key role in the healing response. That means something different depending on what we're treating. I think the example that we're working on now is maybe say like knee arthrosis. So before I even talk about PRP, I'll describe knee arthrosis as a combination of wear and tear changes in the cartilage, so-called degeneration of the cartilage, plus a metabolic process that's like a breakdown type of inflammation. And that combination causes arthritis. And so to kind of illustrate that breakdown inflammation, I'll talk a little bit about what happens when we get a wound. I'll tell, if you ever cut yourself and you get a little bleeding, and your body has a couple of different priorities. The body's elegant, if not anything. And as an organism, when you first get a wound, you, one, don't want to bleed to death. Two, you don't want to die from sepsis. And then three, you probably want to repair the wound. And that's all part of the healing process. And it's not an all or none thing. It's not a 0 or a 1. It's a process, and there's a certain amount for each of these steps. So the body's elegant, and we have platelets which play a role in all three of these. But when we actually do this, the platelet actually plays a role in stopping bleeding, recruiting white blood cells, your soldier cells, in order to prevent yourself from dying from sepsis, but also sends little packets of information outside the platelets that actually draw in and start the healing process. Now, what is that healing process? So you can think of all of this as being inflammation, and there's a part of it that's kind of breakdown inflammation. If you think about, if you're trying to prevent yourself from dying from sepsis or an infection, you want to break down bacteria. So there's like this inflammatory process that's more breakdown. But there's also a build-up type of inflammation that happens a little later. But you can't just switch it from breakdown to build up. So you kind of almost have to like reel in the breakdown, okay, when it comes to that catabolic or degenerative or breakdown inflammatory process. And it's that reeling in of that breakdown inflammation that we're trying to accomplish with PRP. Healing's not an all or none, okay? And we hope to try to ultimately get you to have that build up part of the inflammation. But in the event that we can't, we can at least maybe stall or reel in or slow down that breakdown part of it. And so I'll also describe it to patients that when you go through this process, just like a cut, before you start to feel better, you feel worse. You get a little red, a little swollen, and that's part of that initial breakdown inflammation. And that's why a lot of times patients will feel worse before they feel better. And I go over this with a graph illustrating that. And I often tell them your mileage may vary. Everybody has a different healing capacity between individuals. So, and we'll talk about the differences between that. Some people feel pretty bad in the first couple of days, and then they feel better after a couple of weeks. Some people have a more blunted response. And sometimes the whole curve takes a little longer or shorter depending on the person. And then I kind of lay the groundwork saying that when I see you in follow-up, we're going to be tracking, and it's going to be like 20 questions. I'm going to try to figure out where you are in this biologic response to what we tried to accomplish with PRP. So that's kind of some quick bullet points about how I educate patients, but as you can imagine, it's a little bit more involved than that, but I try to hit those points. And I use a lot of visual aids. I have pamphlets in my office. I got those posters like I talked about. And then actually I use a video. In a busy clinic, when you've got to basically go room to room to room, I'll kind of basically present a little bit like what I've just talked about. And the patient's like, I'm interested and ready to sign up. I'm like, okay, great. Before I leave, I'm going to play this video for you. It's a 12-minute video on how PRP works. And it's going to be a little bit more detailed, and my assistant will be in to schedule you, and I just use that. So if you're interested, you guys are welcome to look at some of those materials. But I try to use multiple different ways to educate the patient. So, all right, thanks.
That's awesome. I'm hearing something coming from the speaker over there. Okay, cool. Gary, fantastic, phenomenal presentation, and I would love to see your video at some point. But okay, so now to the panel portion. Why don't I first just kick it out to any one of you who's chomping at the bit to chime in on anything you would add. When a patient asks you, how does PRP work, what do you say? I think Gary already did well. Dr. Dragu, do you have something to add to that?
Well, many of our communities, patients are pretty savvy these days, and they've done a lot of research. So having a response that takes into consideration a little more depth might be good, like in our area, California, et cetera. They come in and they honestly know a lot. So what I tell them is there are things in PRP that have a shorter term effect or a faster onset, and there are things in PRP that lead to a longer term outcome. What does that mean? And sometimes patients will come up and they'll say, well, I read about it, and everything in the PRP is gone from the knee within a 6-week period of time. Right? That's pretty much the data. And then they say, well, how could PRP last longer than that? Because you're telling me there's a chance that I can have more than 6 months, up to a year's relief, something like that. And so then being prepared for those kind of questions. And the first part is easy, right? The anti-inflammatory factors, depending on what type of PRP you make, whether it's IO1, the acute anti-inflammatory things in PRP, that part's easy. The part that we need to know as clinicians is the longer term part. How could PRP work if it's not even in the joint for a longer period of time? I think the prevailing thoughts are there's a couple of factors in PRP that are adding to a more sustained result. One is the modifying factors of the monocytes and polarization of macrophages into the M2 form. And that includes IL-4, IL-10, that includes the macrophage colony stimulating factor that are in most of the preparations of PRP, and including the platelet-derived growth factor, the fraction BB fraction of that, and that leads to local increase of these MSC cells, these perivascular cells, into the local tissue niche. And so therefore you can have things that last much longer than the components of the PRP because they have a sustained result of the macrophages, and the local cellular milieu. Now that's not a patient thing, but I think we need to be able to respond in a little more technical way so they say, okay, the doctor really knows what they're talking about. So just being prepared for that sort of conversation, that there are things that can lead to a longer result.
Yeah, Eugene.
Can add as well. So a lot of data we can present it to the patient, but also I discussed what options we have on the table. So we have like cortisone injection, hyaluronic acid, and PRP. Then, we compare pros and cons of it, each option. So that make the things a little bit easier on the patient side as well, what to choose from.
Yeah.
PRP is not like silver bullet, it fixes everything, but compared to steroid, it's safer. And compared to a hyaluronic acid, it shows overall it's a better outcome than hyaluronic acid. So that kind of makes things easier for a patient to choose what they want to go.
Yeah.
I'll just add something to that. It's important, we were just mentioning earlier, important to be prepared to answer questions. It's hard to do a huge data dump on them at once, so I often kind of seed it, and then I ask them what questions do you have, and a lot of their understanding will come from not just necessarily the initial foray of ideas, but really from their Q&A. But along the lines of what Eugene just brought about, I sometimes will approach this as goals. I'll say, what are your goals? Most people have 2 to 3 goals. To feel better, be more functional, be able to do their activity. And the third, if we're talking about arthrosis, is many patients will choose to have a goal of delaying, prevent, or avoiding the need for a knee replacement. Not everybody has all 3 goals at the same time, but that's where I'll sometimes use that kind of structure to help them decide what options that we may have presented.
There's also practical information that you need to make sure that they have. What's the downtime? How much pain are they going to have? Are they going on vacation the next day? Do they have a gala? What is their expectations? Because you can go over the data and the numbers, but the pain they have could be very real, and the downtime that you ask them can be significant depending on what it is, depending on what you're injecting. And a lot of patients will come in and they're expecting to get the injection that day when they're coming in. They're expecting it. So you have this whole discussion, you have this this, debate between them on what's the best treatment. And then, you might go over cost and they're like, let's do it. And I say, well, wait a minute. Sometimes we prescribe some pain meds, there's some downtime, there's some medications we need to ask you if you're taking. So there's a lot of practical aspects that can't be lost in the discussion, because if they're not a candidate for one reason or another, it's not worth going into 30-minute discussion on interleukins, right? If they're not a candidate, then they're not a candidate.
So I think maybe I have a less savvy patient population in Cincinnati, so I tend to use the, if you cut your finger, if you're slicing cucumbers and you cut your finger, so platelets come. And then I do have exactly what they're speaking about. I have a patient handout that goes over like medications that they can and can't take and when they need to stop those prior. I talk to patients about timing. I talk to patients about, if they need a sedative, so they're needle phobic. And we'll talk about this a little bit more in my talk too. But I also do, in that, I actually do include some scientific material. So I actually have some of the charts that I pulled from data with the references of what all the interleukin-1 and what they do and how they affect it and some of that timeline. So I sometimes ask patients, like, I have a patient handout that's more written at that like 8th grade reading level, and then I have a more advanced one, and I'm happy to give people whatever information that they need.
That's brilliant. I would love to see that. I would love to see that AMSSM or somewhere have those types of things, what you have on the wall, Gary, and those types. Would love to be able to use that myself. I have a handout that I use, but it sounds like your guys' stuff is better. Maybe you are thinking the same thing, I don't know. But okay, we have a couple more minutes before we need to transition to the next segment. Anyone have questions on how do we counsel patients on PRP? So a common question that I get asked is, well, what about stem cells, and how are stem cells different? And so maybe I'll just toss that one out. I know every one of you could crush that one out of the park, but maybe who's chomping at the bit there?
So the first thing, I often include the stem cell talk within the PRP since I do both in my clinic practice, but the first thing I talk to them is cost. Because if they can't, that is such a niche population, if they cannot afford it, that kind of goes to the back, of the table. But I always talk to them about, we can even do a stepwise approach. If someone has, even if this, in Cincinnati, we charge $750 for our platelet-rich plasma. So I may even talk to them about, you've got a NEOA, let's try a hyaluronic acid injection since that's covered by your insurance. Then we'll do our PRP, because there are some studies that show that they can work in tandem. And then I always talk about, like, these are the options. And so I go through both, but and stem cell costs, like Shane mentioned earlier, there can be some I've seen ranges of people paying $10,000 to $15,000 for a single joint to, $5,000 to $6,000. So the first thing I talk to them about is that it is cash pay, and 20% of people will not respond. Mm-hmm. And usually I'm very upfront and honest about that, and people, I think, appreciate that. But then I go to show, but these are the benefits. These are what the studies show. And again, talking about goals. What is your goal? I want to dance at my daughter's wedding in 9 months. Okay, that is an achievable goal. If they've got a deformed valgus knee that has a huge shift on it, and they want to straighten their knee out, guess what's not going to work for them? Stem cells. So this is where you just kind of have to have that upfront, honest conversation.
All right. So Gary, 30 seconds. Patient asks you, why not stem cells? Why PRP or is stem cells better? 30 seconds. What do you say to the patient?
Well, I say that one, look at the data depending on what they're treating. If you use knee arthrosis, what you get. I always use the analogy. The juice may not be worth the squeeze from a cost standpoint, as well as perhaps what we're able to accomplish. The second thing is, I'll tell them, I'm allowed to tweak PRP. I can't tweak your quote-unquote stem cells. This is after I tell them why we don't call them stem cells anymore. But I'll tell them, that I can tweak your PRP. And I know there's going to be more about this to optimize it for your age, your metabolic determinants, your other cofactors to get the best outcome. But I'm not necessarily able to do that with your MSCs.